Hello, I'm Joe Cleveland, an adult cardiac surgeon and chair of the STS Health Council Policy and Relationships. This ask is for Congress to prevent damaging cuts to Medicare reimbursement for cardiothoracic surgery. Unfortunately, for the past several years, the Centers for Medicare and Medicaid Services, also known as CMS, has proposed and finalized rules that would cut Medicare reimbursement. This presentation will provide some basics about the policies that have led to these cuts being proposed once again this year. However, please understand this topic is fairly technical. You are not expected to be able to explain Medicare payment policy to your members of Congress or their staff. In fact, we recommend you always bring the discussion back to the impact that these policies have on patients, their constituents. Your personal anecdotes about how this affects you, your workplace, your practice, and your patients are always extremely powerful and far more important to a successful meeting. And as always, if you are asked a question during your meetings that you cannot answer, you can always ask STF staff to follow up at a later time. CMS reimburses physicians for care furnished to Medicare Part B beneficiaries based on the Medicare physician fee schedule. CMS updates the physician fee schedule rule annually. They publish both a proposed rule to allow for public comment before finalizing its policies and the final rule. STS comments on the rule annually as a large portion of cardiothoracic surgery is paid for under the physician fee schedule. Medicare currently pays surgeons and other specialists a single fee called a global payment when they perform major procedures, like most of the surgeries that we perform as cardiothoracic surgeons. This fee covers the cost of the procedure plus related care both before the procedure and follow-up care within a 10 or 90-day time frame, depending on whether it's a 10-day or 90-day global period. The services provided during pre- and post-operative visits are the same type of services that could be provided as standalone evaluation and management visits. Several recent CMS policies led to a proposed 8.5% cut for cardiothoracic surgery, included in the 2023 physician fee schedule. Beyond surgical specialties, these cuts impacted many physicians and non-physician specialties, including infectious disease, pathology, critical care, emergency medicine, ophthalmology, and physical therapy, among many others. This is a broken system that requires any improvement to one specialty be met with damage to another. This instability has real consequences to patient access to many of the treatments and surgeries that are most crucial for the Medicare population. Let's discuss a concept known as budget neutrality. In the late 1980s, because of skyrocketing professional healthcare costs, Congress passed significant federal price controls in the form of the Sustainable Growth Rate Formula, known as the SGR. Although Congress has now dispensed with the SGR, the resource-based value or RVU-based fee-for-service system is still able to control growth in physician payment costs through this budget neutrality mechanism. Federal statute dictates that when CMS adjusts RVUs to account for either changes in medical practice, coding changes, new data on relative value components, or the addition of new procedures that result in a change of spending of more than $20 million, that they must make a budget shift. In other words, CMS must make a budget neutrality adjustment so it does not result in an overall increase in CMS spending. So this is referred to as a zero-sum game in game theory. A crucial factor in understanding this is that both the frequency of billing a specific code and increases in reimbursement for that code will result in overall cost increases. So for an example, when tiny tenths of RVU increases were granted to the evaluation and management codes 3 years ago, these codes are the most frequently billed codes under the physician fee schedule. They result in hundreds of millions of dollars of increases that comes out of everybody else's pie. So in the upper right, we see a budget neutral scenario where if an increase occurs, a corresponding decrease has to happen in a corresponding specialty. In a non-budget neutral increase, shown in the bottom, if Medicare reimbursement were allowed to increase in this fashion, the pie would simply get bigger rather than subtracting pieces of pie from somebody else. This is one of the most important slides in the presentation. This is a slide describing Medicare updates from the periods of 2001 through 2021. The y-axis is the percent increase since 2001. On the x-axis is time. Please note the various groupings. Inpatient hospital, outpatient hospital, subacute nursing facility all had a 60% increase in Medicare updates. Meanwhile, inflation, or the consumer price index, rose about 50% during this time. Practice costs, as shown by the Medicare Economic Index, in this green bar shown in the middle, went up about 35–40%. Lagging on the bottom line here in the black boxes is physician reimbursement. So we, as physicians, have roughly seen approximately a 10% increase in our Medicare updates over this 20-year period. However, when one compares that to the consumer price index increase of 50%, that's a 40% net cut. So it also demonstrates that physician reimbursement lags far behind the reimbursement given to hospitals and other nursing facilities. Stated differently and shown differently is the reimbursement for Cabbage, shown in this slide. The blue line shows how we've done since 1987, when we were paid roughly $4,000 for a Cabbage. In absolute dollars, we are now paid about $2,300 for a Cabbage. However, this orange line adjusts the dollars for inflation. So if we actually adjust our reimbursement for inflation, you can see that we are paid just under $1,000 for a Cabbage in 2021. Similarly, for open lobectomy, the purple line on top, again, absolute dollars, shows that in 1992, we were paid roughly $1,200. It's now about $1,500 absolute dollars in 2022. The orange line, however, adjusted for inflation, again suggests that about $1,000 was a payment for lobectomy, 1992. That has decreased to roughly $600 for lobectomy. So what happened in 2022? In 2022, surgical specialties, including cardiothoracic surgery, narrowly avoided cuts to Medicare reimbursement when Congress stepped in and added new money to the Medicare pool, giving all physicians a 3% raise over the CMS proposed rates. The fix, however, is temporary. It expires on January 1st, 2023. In addition, there are budget control mechanisms called pay-go and sequestration that will even further deepen cuts at this time. So what's the bottom line? The bottom line is the impact of these cuts. When cuts to surgical care are implemented, it harms patients by threatening access to critical treatments and procedures. Remember, 4 out of 5 of the leading causes of death in the United States are treated to some extent by cardiothoracic surgeons, including heart disease, lung and esophageal cancers, and chronic obstructive pulmonary disease, or COPD. The healthcare system has undoubtedly been strained over the past year due to the pandemic. These cuts will put further strain on the healthcare system. Hospitals will reevaluate staff contracts and reprioritize procedures. Surgeons may take fewer Medicare patients, thereby leading to longer wait times and reduced access to care for older Americans. Cardiothoracic surgeons have struggled to maintain private practices, as now roughly 80% of us are practicing in hospital-employed situations. These cuts will all but ensure surgeons in private practice must shut their doors and go join healthcare systems. Our patients deserve a healthcare system that invests in surgical care, does not create uncertainty year after year. So this is what we need to do. We need to ask your elected officials to support congressional intervention by maintaining the 3% increase of the conversion factor through at least calendar year 2023. Ideally, this time will be used by Congress and outside stakeholders like the Society of Thoracic Surgeons to work with policymakers on a sustainable, long-term solution that protects patients without pitting doctors against each other. Thank you.